Okay, so what I'm going to do the second half is I'm going to do a little brief background and then ask you to work at your individual tables on some cases. And you have the PowerPoint, where's my clicker? Here it is. What I really want to do now is get you a little bit more specific in terms of addressing ethical dilemmas. And the cases are all ones in which we can basically say there's more than one way of acting that we can justify. So, let me see. Ah, it worked. Okay. Let me make sure that's the right slide. Okay. To start, a real ethical dilemma, and I stress dilemma, involves a conflict in values. I gave you some examples, safety and risk, for example. And it's a situation where more than one way of acting can be ethically justified. And that is what we call, which I mentioned earlier, what we call a right-right dilemma, not a right-wrong dilemma. Right-wrong is, literally embezzlement, knocking over somebody on the street because you know that person is a good match for you and you need a new kidney, just kind of helping yourself to his kidney. Those are wrong. But the right ones are the ones that leave us uncertain and leave us not knowing how to act. And when I said earlier that there's no neutral starting place, it's we all bring something to it. And some of us are much more concerned about safety. Some of us are much more comfortable with risk. Sometimes we notice problems in large measure depending on who we are and what our own backgrounds are. Nurses and social workers often think differently about cases because of their professional background. So anyway, the hard ones are these important right dilemmas. So what you find when you encounter one of these right dilemmas, you've got to figure out what is the real problem, what is the conflict here, why can't you decide what to do, why is this a dilemma for you, and you try to think about it as if it's on a balancing scale, and somehow you have to come down on one side or the other. You have to, it may be difficult to decide, but you have to decide. So one of the ways that we go about deciding, how we go about doing it, and you have this on the slide, is we need to go through a process of moral reasoning to think about it. And there's a fairly systematic way that we use to go about thinking about these particular kinds of cases. And I'll just give you a few examples of the kind of moral reasoning that we do. Now, most of you are probably familiar with, because we use it very commonly, are the four principles. Notice I do not have it up there. Autonomy, beneficence, non-maleficence, and justice, because I find it a very narrow focus. It doesn't ask us to weigh, it tells us to weigh and balance these things, but it really doesn't give us any tools by which we can work. So here we are, we've got two sides. We can argue we can argue this way or we can argue this way. How do we decide? How do we decide which side we come on? So I'm going to very briefly, you probably, for those who have had any philosophy, will know these things, but let me quickly do it. Ends-based thinking, in some ways, would be beneficence. Ends-based thinking comes out of utilitarian philosophy, Jeremy Bentham, John Stuart Mill, for those of you who are familiar with these. And what they do is say, when you look at a situation, what you want to do is look at the outcomes. For all the stakeholders, perhaps for the patient or the client, for a family member, for the community, you're always looking at outcomes. And it means that you need to anticipate how, if you acted in A way, what would happen, and if you acted in B way. And you're always looking at harms and benefits. So ends-based thinking is something we probably all do all the time because we are often weighing harms and benefits. So think about it, but you've got to involve all the stakeholders. And my objection to principle-based thinking is you tend to look at the autonomy of the client as if she or he is isolated from the context in which that she lives. Rule-based or principle-based thinking, again, for those of you who are familiar, is really Kantian thinking, and it's based on duty. And sometimes you may say, and this is where people who use traditional ideas of autonomy most will say, you have a situation, like Tom that I mentioned earlier, which works out to be kind of a potential self-neglect case. Well, he's competent, he can make decisions, there's a rule, we don't interfere with anybody who make decisions, and you apply a rule that comes out of your professional obligations, your sense of duty, your belief in how things should go. And so the problem with rules is you have to say, in all such circumstances, this is how we should behave. It's a duty-based way of thinking. And we've modified, Kant some, because we say that most of the duties we face, we call them what we call prima facie duties. And for example, I'll just use the issue of truth-telling. Most of us would believe for the world to go well, for our caregiving to go well, telling the truth is really an important thing. But we don't always tell the truth. And there are morally justifiable reasons for not telling the truth in certain circumstances. But because it's such a strongly held moral value, telling the truth, we have to have really compelling reasons not to tell the truth. And I'll give you an example that has nothing to do with the work that you do. But this example is, a very large one. Many years ago, during the Second World War, as you know, the Nazis occupied Denmark. They occupied lots of places, but this example is about Denmark. And it was a fairly light occupation in terms of the Jewish population, until rumor got out that the Nazis were going to crack down. And they were going to round up all the Jews in Denmark. And the Danes, through whatever system they had, a very trusting society, managed to, by word of mouth, get almost the entire Jewish population to the seacoast. And then they were able to get passage to Sweden, which was, Sweden was neutral during the Second World War. And so the King of Sweden said, if any Jew can get here safely, you are welcome. You can stay here. But that meant the ship captains, the Swedish ship captains, had to hide people in their ships. Hide them wherever you hide people in ships. So this is an example where it's a prima facie duty to tell the truth, but if you were a Swedish ship captain in Denmark's territorial waters that the Nazis controlled, and you had a shipload of Jews in your ship, and the Gestapo boat came up alongside of you and said, are you hiding any Jews? I would hope you would lie. I would hope you would lie. That would be, the duty to override truth-telling was because such great harms can result. So truth-telling is a prima facie duty. We must do it unless there are compelling reasons not to. Now, you will run into probably circumstances like that sometimes in your work. Don't tell my father he's dying. Don't tell my father he's dying because he'll get depressed, he will give up hope, he'll try suicide. And in most cases, we'll override that. No, you've got to tell the truth in order to get informed consent, in order to treat. But if there's really, really, really strong and compelling evidence that suicide is a real risk if you told him the diagnosis, and there was a good reason to believe that treatment would work, you may not tell the truth. You may delay it. You may wait till the patient asks you. I'm not suggesting you do that. I'm suggesting there may be compelling reasons not to tell the truth. So ends-based thinking, rule-based thinking. Ends-based thinking, you look at outcomes. Rule-based thinking, you look at rules, at duties. Now, feminist and narrative thinking is more difficult to explain, a little bit because it's atheoretical. there's no effort to develop a theory. Utilitarian end-space thinking is the greatest number for, the greatest good for the greatest number. It's how we do public policy. Kantian thinking is very clear about our duty. But feminist thinking really says to us, well, what about relationships? If Mrs. Jones, and this is a case that we'll do, if Mrs. Jones insists on staying home, like the Raven case I mentioned to you, but her daughter has to quit her job to take care of her, is it enough just to listen to what the person wants without looking at this relationship that can be challenged and threatened? It asks you to pay attention to particular context, and it doesn't have universal rules. It says there are very often solutions that work best in certain situations that would not work, let's say, for other families and others. And there's a lot of use of narrative, trying to figure out what will work best, get people to tell their stories. It's a much wider rule of engagement. So when we have the situation where we don't know what to do, when we can go A or B, we will apply different forms of moral reasoning. We will ask ourselves, if I looked at it through an end-space, so outcomes, end-space, if I look at it through duty and rule, if I look at it through feminist and narrative, and these are the dominant forms of thinking, which comes out, where does the balance go? And then you need to make a recommendation, because we have to act in these kinds of circumstances. So you need to determine what you would do, and most importantly, be able to explain the reasons. You'd be able to say, I choose A. I think there's a stronger weightiness toward that, and here are my reasons why. And when we do any kind of a case analysis, we do those kinds of things. We may ask for facts, we look at the variety of options that are available to us, because sometimes we may find that we don't have to choose between A and B. Maybe there's something in between, that we get a little bit of both. But we're going to practice it by doing a number of cases. The next thing on this slide are questions about ageism. And I think what I'd like to do for now, instead of doing that, because we need to start talking, is actually look at, there are two cases here. One about Drew Atkins on page 3, and then the next case, I can't turn this page, is about Drusilla Barnes. And what I'd like you to do is in your among your at your tables, let's say this half of the room did the first case, Drew Atkins, and the second half look at Drusilla Barnes. And what I'm going to ask you to do is first decide, is there more than one way of acting? Can you make in this particular situation, can you defend more than one way of acting? And be real clear about what those choices are. Be very explicit in laying out those choices, and then begin to ask yourself, well, if I do A or if I do B, what are some of the outcomes? Are there any rules? Are there any relational issues involved here? And let's see where we come up. It's a very hard room to do this kind of, because I'll ask you, we'll come back and we'll talk about them. But if you would just, again, this half of the room do one case, this half do the other, and then we'll come back and talk about it. So why don't you spend some time looking at the case? I hope they're familiar to you. And I will... Okay, why don't we come back, everyone? start with this side of the table. We're doing this side of the room, doing this first case, and we're waiting for the mic. We'll leave the microphone so we can hear each other. I don't know where they are, but they may appear. You've got one, okay. We're starting on that side of the room, okay? So first of all, the question that I asked, the case of the Atkins, which you all have in front of you. Is there a conflict here that you could defend more than one way of acting? Is it a right situation? And who might like to start? Any of the tables? It's a basic question. Is it, can you defend more than one way of acting? And of course, my second question will be, and what are those choices? Don't try to all speak at the same time. Yeah, stand up. That would help.
We had more questions than answers, really. The first question is what his wife's level of functioning is, and if she wants to be, if she can, if she's capable, and if she's willing to be the caregiver. And then if not, if she's too ill to be the caregiver herself or overwhelmed, Mr. Atkins would probably have to be presented with some choices like maybe in-home care or maybe short-term rehabilitation depending on his level of functioning after the stroke, or long-term rehabilitation. But we thought we'd start with asking those questions. And then it also may be a situation where Mrs. Atkins is too afraid, not so much afraid, for any kind of repercussions, but afraid to tell him that she can't do it, and she will do it reluctantly, and both of them will, decline. We've seen that too.
Okay, so one of the things for some of these cases in which we don't have answers, we often stipulate, we'll often say, let's just assume, because it's not a case that we know the details of. Okay, so one of the questions I want to follow up that you just asked, and then we'll ask others to do this case, is Mrs. Atkins, given the circumstances, given the domineering personality of her husband, and all that, is she really able to make a truly autonomous choice about what her actions should be, and what then would be the role of the social worker in helping her come to an autonomous choice? Remember, autonomy means you have meaningful choices, that the choices that you have are part of who you are, what you want to be, are feasible for you. So it's an important question, what does she want to do? But I do think we have to maybe consider her willingness to say, I can't do it, given the relationship. Feminist ethics would look at the relationship these two have historically had, and then raise the question, is this the kind of relationship in which she could have said no? Any other tables have comments?
That to me, that suggests that she's, I don't know, that's a whole other ageism kind of thing when you say, can she really make an autonomous choice? She's chosen to live with this man forever, apparently, because they have grown children, so they've lived together for a long time. An autonomous choice, just because it's not one that you or I would make, it doesn't necessarily, because she may say, yeah, I know this is hard on me and it may end up killing me, but I'm going to do it because this is the man I've chosen. This is the way I'm going to go for the rest of my life. I really don't need a microphone anyway. For me, my first question is, what does she want? And yes, I think she could make that choice. Whether it's a choice I would make, probably not. My best guess is she's going to say, he's my husband, this is the life we've lived, we're going to continue to live it until I am in the hospital, and then we'll figure out a crisis plan.
Okay, I was not, when I said suggesting that we impose. It's not but how do we work with her to make sure that it really is, and that perhaps she can actually say no. I mean, she may not, I'm not suggesting that anybody tell her what to do, but at least a feminist ethics that looks at the particular circumstances that people are in, that looks at the relationship that they were in, that looks at the habitual role that women have played, particularly a woman like her. Just work with her to maybe help her understand that she does have choices, not to impose it, but to work with her to suggest that there may indeed be choices that might be good for both of them, because if she collapses, there'll be nobody left. So not in any way trying to impose anything, but just helping her to grapple with what's available to her.
Yeah, my question is really, first of all, who's the patient here or the client? But more, I think more of the point is, if someone's been in the hospital for a week with an MI or a CVA and they ask to go home, it becomes initially a medical problem. So in this case, I would think a medical team could simply say, you can leave now if you want, but probably the insurance isn't going to pay for this. And that's your choice if you want to do that. And the other part is that a medical team, which would include social workers, et cetera, would probably say, the level of care you need at this point, based on your medical condition, precludes your wife from taking care of you. It's a sort of a done deal. For me, this is a relatively simple ethical question in terms of lots of more difficult ones.
And so you would say that even with home health coming in, not a home care aid, but home health coming in, that the medical decision would be you can't go home.
I'm not. It depends on what they arrive at together, but there should be a meeting about that, and I think he should be informed of his status and the consequences of leaving early. For me, that's the way I think of it.
And again, when I talk about the limits of autonomy, to really make a truly autonomous decision, it is essential that one has all the information, as much information as necessary. Remember, we talk about informed consent, not just consent. So what you're suggesting is that part of it, not only do we inform Mr. and Mrs. Atkins about some of the consequences for her trying to do it, but looking at very seriously, is this a wise thing to do medically, at least laying it out that they have it all before them.
And I think the other thing I want to know is what effect did his CVA have on his capacity to be thinking right now? I mean, that's clearly another part of his education.
And what you're suggesting is, which you probably all know this, but an essential part of an ethical analysis is to get the facts, as many essential facts. You're always asking yourself, are there more facts that I need? Is there something else that I need to know? Because there may indeed be, and that may change the ethical case. So what you're suggesting, with a certain amount of facts, particularly about his medical condition, the ethical problem may go away.
Yeah, maybe I don't need a microphone either. Basically, it seems like there are issues. There are issues. Oh, it does work. Okay, good. We basically decided there were issues of dignity, of independence and autonomy, and of duty, and that all of these things are mixed up in the equation. And then there are some fears. What's this going to cost me to get proper care? How are we going to proceed? What's it going to be like to have someone in my house or for me to be in a facility? And so all of those things are part of the informed consent process, which has to be gone through with both of these people. And it is a right. I think that basically both of them could be right depending on how ill he is and how, if he's a 5-foot man and she's a 6'5" woman, it might be fine. If it's the opposite, it might not be. So there are all sorts of practical decisions, but it's part of, for both of them, it seems to me that it's an informed consent question. And those things may, with all the information, may come in and make the decision, or may not.
And this would be the usefulness of narrative. You get people to talk about not only the medical condition, But what it's, she said to him what it's like for her, him saying why it's so important for him. And again, this would be, a feminist ethics of care would stress these kinds of things. That again, informed consent or consent or autonomy demands these kinds of conversations, these means of exploration, to ask questions that you might not ask if you adopt a narrower view of autonomy, which is uncoerced choice. So what you're getting is, which I'm glad, is just a much larger notion of what it means to act autonomously.
I just have a question.
Is it working?
Would you meet with this individual, with the female by herself, to ensure that you're getting what she really wants? Because maybe if she's with her husband, because she does have duty to him, you do have a duty to your spouse, that maybe she wouldn't be as honest as she would be if she was by herself. And then after you speak with her, then go and meet with them, the two together, and maybe help her be able to verbalize what her choices are.
This is a perfect example of what I said, that the ethicist just outlines what the ethical, what you can justify ethically, and then you turn it over to the clinicians, and you figure out how to do it. So you probably know better than me. I can say that talking is really important. That again, for reasons of consent and autonomy, but it's the clinician, the practitioner, who has to decide, do I do it alone? From your, what we call your moral experience, what would be the most effective? How would you go about, given that ethically you can justify trying to engage her, trying to get her to fully understand that she, just get her to understand why she's saying what she's saying, that she has permission not to do it, and all the things that you might do. But how you go about doing that is up to you to figure it out. And that's really it's actually a perfect way of saying that our ethical problems take place in our practices. The ethicist can just lay out what can be justified, but then it's up to the clinician to figure out how the best way to affect the action.
Hi. From a nursing standpoint, then we have to look at how competent is he. He has mild cognitive impairment, so is he competent enough to make the decision to go home? They have to find out that part before they let him go. And if he insists and he's still he's incompetent, he can sign against medical advice. And ethically, the nursing staff and the doctor in the hospital are not at risk because he signed against medical advice. So then you have to look at also, like they were saying about the stroke.
And that's more the facts we would be gathering.
Right. And with the stroke, does he have hemopharesis? Does he have weakness or where he can't use one side of his body? So that's putting a lot of stress on the wife because I don't think she would be competent enough. I mean, I don't think it's safe enough to put them in that risk because it's a risk factor as far as safety and health for both.
And in some ways, sometimes all this medical information in some ways could be face-saving for her too. That not only might she get his program for not doing it, but that she really can't do it, for a variety of reasons. Let's take one or two more comments on this side, then I want to do the other case. Did you have a comment on this case, or wherever the microphones are, whoever's going to speak?
I just wanted to say, I think they need to be given their options as far as he can go to rehab. People think that when they go into a nursing facility, that's the end. They don't get to come home. I think she needs, as a case manager for Passport, we find ourselves in these situations many times. And we need to inform the families of their choices. You can go to rehab for a little while, gain strength, come home. And I think it's important for us to give her permission, or maybe she needs it from her children, to say, Mom, it's okay to say, I can't do it anymore, I need help. We do have, responsibility towards our spouses or significant others, but we also have towards ourselves. She's ill, she's got CHF, arthritis. What if something happens to her and she can no longer care for him? And I see nothing in here, and of course, you know, we have to read between the lines, but we have, you know, to give them their choices and to make him understand that. Now, because he was authoritative in his younger years, oftentimes we have to put our foot down, like I was telling my table. We have to be straightforward. You no longer run this. And it's only in your best interest that I say that. And sometimes we have to be stern like that, but that's how they get it. They get it that way. If we sugarcoat it, then they're going to go around and around and around. But my thing is, we need to take care of her because she's ill, and if something happens to her, they'll never come home. And the other thing is, if he does come home, they do send him home, and he comes home, and the skilled nurse or skilled aide that goes there once or twice a week, whatever, sees that it can't be done, call APS.
I'm only laughing because Brian is the one I told my almost 5-year-old grandson this past weekend that he's not the boss. And he said, yes, I am. But I mean, you know, perhaps what you're doing is really ethics of care. You know, you're doing narrative, you're doing the relationship is what important, that if she gets herself so worn down, there's going to be nobody to take care of him, and that a relational, what we call relational autonomy, really demands that you look at all the stakeholders, not just the one person. Okay? But let's say one more comment in this case, then I want to look at the other case, because I'd like to do a little bit of end-of-life care before we quit.
I have 2 comments. First of all, I work for an assessment center, so I just wanted to clarify mild cognitive impairment. You know, that's what the fact is. Means that your ability, your cognitive impairment might affect a little bit of some forgetfulness, but you have the capacity to function, say pay bills or whatever. He might physically be incapacitated to drive for now or whatever, but mentally he's capable of decision making and problem solving. And secondly, I like the idea of empowerment of one of the children. You know, that's great that they send money in that, but for this case, possibly, is there someone that could come to empower their mom during this, you know, if there's a case conference or something to problem solve, you know, or someone, as they said, to take her aside to empower her. Is there a doctor involved with her care as well to support that for now, you know, she doesn't have that capacity to take care of him physically. Again, skilled care, all that stuff. But, you know, those are my 2 comments, but basically to empower her one way or the other.
Thank you. And what that again does is remind us that the action we have, that intervention is okay, that it's not simply what he wants, and if she feels it necessary, that we can engage them in an ongoing conversation about it. And thank you for the comment about mild cognitive impairment. I remember the report from Family Caregiver Alliance a number of years ago on their study of decision-making capacity with people who had Alzheimer's, and it extends much further into the disease process than we had earlier believed.
So that's different from dementia?
Yeah, well, I'm assuming this might be an Alzheimer's form of dementia. Okay, why don't we do the Drusilla Barnes case? I'll get there. Okay. And whoever wants to speak to it on this side of me. And somebody is ready to jump out of her seat.
Okay, we'll start. I just want to see, was that Evelyn over there telling him he don't run it? We'll get one of the kids to tell him that. But we talked about the Drusilla Barnes case, and one of the things that came up first with us was whether or not Mrs. Barnes had the capacity to make good decisions as well. We knew that she had some mild dementia, which probably means that she's not incompetent, but does she have the capacity to make decisions? about her care at this point. We looked at the fact that she was a double amputee and had some diabetes and other chronic illnesses that certainly justifies her ability not to get out of bed and answer the door very quickly. And so we looked at and talked about some technology systems that may be put into place to assist her with that and make it safer for her, like a keypad or a lockbox, that she then could designate an individual to have the ability to come into her home, including the home care assistant if she so chose. But we also looked at whose definitions are we using in terms of whether or not her home is cluttered. And Lori here said that when she looks at some of her residents, she looks, are there clear pathways? And not whether or not the table is cluttered or a corner is cluttered, but is she safe in terms of navigating throughout her house? And if that's so, then is this an instance of the home care assistant's tolerance or definition of being safe or unsafe is interfering with what Mrs. Barnes believes her safety issue and her capacity to continue to live in her home? And is there then a need for the care manager or case manager to take a look at that and help the team to make some decisions about what Mrs. Barnes wants versus what the caseworker or some of the team members want, because that can be very different. Noting that she has some mild cognitive impairment, we believed that there needed to be an ongoing monitoring of her cognitive status so that we can be aware of the changes as they occur and perhaps a greater need of assistance or helping her to make some decisions.
Wow. Let me just give you a little bit about the safety and risk issue. Some years ago, Bart Colopy from Fordham University did a very, really well-done chapter. Unfortunately, the book is out of print on which it was in, but it was about safety. And he was looking at safety in terms of psychosocial safety, you know, the kind of things that most of us want. Again, thinking that autonomy allows us to live in habitual ways, and she wanted to stay and live in habitual ways, compared to the safety that professionals or children, grown children often think about, which is protecting you from falling, or, you know, the physical protection. And there's always a struggle to whose definition of safety that one uses. So that was an important observation. Okay, any more comments on this case?
Our table.
Where's the voice coming from?
I have one, but I'll wait for whoever's talking.
Our table looked at this case as well. We looked at evaluating Ms. Barnes with the home evaluation, and we also considered her environment. We decided that we would assist her if the clutter presented some safety issues, to offer her chore services. And sometimes, depending upon the clutter, you know, if she's able to make those decisions, what she wants to get rid of, and just creating some paths, you know, as far as safety is concerned. And also, after her care is completed by her aide, we would also look at the community, at the neighbors, at churches, at other family members that could come in and assist her after her aide is gone, since she's receiving the maximum care through the waiver program. And we looked at getting her the emergency button, if, you know, depending upon her memory and her dementia, if it was mild enough to get emergency button.
And we thought she could stay in her home because all of her needs could be addressed with her personal care and getting her bedside commode, depending upon if she could transfer or not. And just considering, you know, her needs, making her part of the decision, in every decision, decluttering her home, the services that she wanted, when and who she wanted to come in, but just giving her those options and to allow her to keep her independence and stay in her home, which we think she would do much better.
And so what you've come up with is what can be called the trilemma. You're not going to, it's not going to be either or, but you're going to come with all different ways that she can continue to get what she wants. And let me give you one suggestion that a philosopher made when she was trying to balance what paternalism and autonomy, and said that the important thing is to work together to determine what the person's goals are. And once you reach some agreement about goals, that both the professional and the client, I use the word client because I think there's a different moral relationship with a client than with a customer or consumer, but I know language is a big issue here. But that you seek to, that she thought that can bridge paternalism and autonomy by coming together around goals. What does Mrs. Barnes want this period of her life to be like? What does she want to be able to do? What's really important to her? And how can you best achieve that? So you had some remedies, but it might, and you said at the very end, you said involve her in all the decision. It's really, so I think if we add in the sense, but what's really important to you? What do you value? What do you want to happen? And how do we get there? And that might be an important thing to do. All right,
Dr. Holstein? You know what, that's exactly what we said at this table. Our first choice, our first thing we would said was, what does the client want? Who does the client know? Who can she bring her to the table for herself? Okay, because this A does not know what her extended support system is. And she asked her, what does she want? Okay, obviously she's got strength, she's got a neighbor that's coming in. Okay, so obviously you need to ask the client, what is it that you need, that you want for the autonomy? Exactly right.
So this all involves conversation, narrative, goal setting, and involving the person in everything. Any other comment on this case?
Right here. Over here. Right here.
I know you're probably looking on that side for the comments, so that's okay. But one of the things that stuck out for some of us with case number 2 that hasn't been addressed yet is a very small sentence that stated that this is one of the case aide's favorite clients. And one of the things that we have to always be aware of is the ethical boundary issues that we sometimes overlook when we become too involved in the process, either as the aide, as the care manager, as the provider. I know so many times we get calls from aides all the time saying, oh, I think they need more hours, or I really don't think that they need to be doing thus and so. And so we always have to revert back to their service plan. What is the client's need? What is in their best interest? And get them to look at it from that perspective. Are there boundaries being crossed here? Is there some kind of enmeshment that is going on that needs to be addressed? If this particular aide was removed from this particular caregiver role, then what would that opinion look like from a different provider source or different aide? The other thing that we talked about was the idea of posing to Ms. Barnes the option of an assisted living facility where she can maintain her sense of independence in an environment that will still provide those very basic support services in a around-the-clock type of atmosphere. So those are a couple of things that were red flags for me that stood out that are minor, but I think sometimes those kind of things get overlooked when we're talking about autonomy for some of our clients.
Okay. Well, I think we don't have much more. Do we have any time at all? My timekeeper? None? All right, well then, what I want to call your attention to, since we're not going to get to talk about it, is some of these, this is an exercise, if you've got any ideas, do send it to me. But looking at end-of-life care, I'm not going to get to talk about it because we have to stop, but I would like you at least to take a look at it and look at some of the limits of why we're still a long way from getting the kind of end-of-life care that we want. There's some really good ideas and what can be done about it. And in a shameful, absolutely shameful plug, I will say that I wrote a book with a couple of colleagues a few years ago called Ethics, Aging, and Society, The Critical Turn. And there is a fairly detailed chapter on end-of-life care in there. There's one on long-term care, there's one on Alzheimer's, there's one on public policy, there's one on self-neglect. So if you're interested in pursuing it, take a look at the book. I mean, Ethics, Aging, and Society, Holstein, Parks, and Waymack. And thank you all very much for a very enlightening meeting.